All right, so anxiolytics. Anxio, anxiety, lytics means to break. So we're breaking anxiety today. And this is just a summary slide of the entire lecture, and that'll be it. Thank you for listening. Just kidding, I wish it was that simple. These are the learning objectives. At the conclusion of this lecture, you should be able to define basic psychopharm terms. You should be able to explain the theoretical and general mechanisms of anxiolytic medications. And you should be able to review the classification and mechanisms of anxiolytics and sedative hypnotics. This is a slide that you may have seen before. Essentially, it's just a table with a summary of all the major disorders and the different pharmacological treatments. I'd say that if you know this table, probably are going to be able to answer the treatment questions for many of the questions on the USMLE and NBME. But again, this is just a summary slide, so this is not all-inclusive. So a few definitions: psychotropic medication. So this is any ion or compound that's used primarily to treat the signs and symptoms of psychiatric disorders or mental disorders. We would say psychotropic medication, for example, when we're using valproic acid or Depakote for bipolar mania, and we would call it an anticonvulsant medication when we're using it to treat epilepsy or seizure disorders. Agonists produce an effect on signal transduction that's similar in direction to the naturally occurring neurotransmitter. Antagonists produce no change in signal transduction, so when the drug binds to the receptor, it doesn't activate it. Partial agonist essentially changes or produces a change in signal transduction which is in the same direction like an agonist, but it doesn't do it as much, so it's a little bit weaker. Inverse agonist is different than an antagonist, and it differs in that when we think of an inverse agonist, well, let me take a step back. All receptors, all cell surface receptors are sitting on that cell surface, and what they're doing is they're sort of vibrating, right? They're not just sitting there still, not doing anything. They have some intrinsic activity. And when we give an antagonist, what we're doing is we're basically blocking that receptor's ability to produce a change in signal transduction. When we give a inverse agonist, we're actually decreasing the intrinsic activity, which means that it's going to go in the opposite direction. The signal transduction is going to, or the activity is going to go in the opposite direction of what the naturally occurring compound or neurotransmitter would do. And that's important because antagonists, when you look at the activity curves of antagonists and inverse agonists, which I didn't have on this slide, but when you look at one of those diagrams, it will make much more sense. The allosteric modulation is essentially when an ion or compound acts at a secondary site on the receptor that isn't the active site. And then the binding affinity is just the van der Waals forces between ion and compound and its receptor, and it's basically expressed as 1 divided by the dissociation constant of the medication. The dissociation constant is a measure of the concentration of medication needed to saturate 1/2 of those receptors. Okay, now that I've bored you to death, let's just continue. So, general principles and mechanisms. So most psychotropic medications alter signs and symptoms of mental disorders in one of two ways. One of those ways, they bind to primary or allosteric sites on ligand-gated ion channels, and this will usually produce an immediate effect. For example, the benzodiazepines, when it binds to the GABA receptor, causes an increase in chloride influx into the neuron, hyperpolarizing the cell and inhibiting its ability to produce or reach threshold for an action potential. This is a relatively fast acting mechanism. The second is initiation and adaptation. And essentially what this is, you have to remember that whenever you're kind of repeatedly disturbing a system, that particular system is usually going to want to come back to the way it was before, right? So if you alter something in the brain, or any system for that matter, most biological systems, you're going to alter it in a way that kind of throws it off balance. And what is it going to want to naturally do? It's going to want to come back to that state of balance, what we call homeostasis. So what ends up happening with many medications, and I would say the majority of medications in psychiatry, are thought to use this particular general mechanism. That is, they alter signal transduction in very complex but delayed ways, and it's the adaptive response to the medication that ultimately leads to therapeutic efficacy. So it's not necessarily you take this medicine, for example, an SSRI, you take the medicine and it's not like automatically you feel wonderful and you feel just like so happy, right? It takes time, and the reason why it takes time is because there are signal transduction cascades going on, and gene expression changes that ultimately lead to long-term changes in either synaptic connectivity or growth factor production, etc., etc. So basically, with this second mechanism, it's not a quick effect. It typically takes from anywhere days, weeks to months to show an effect. Examples: the SSRIs and SNRIs are classic examples of initiation and adaptation. All right, anxiolytics. We're not going to cover all of them. We won't cover the SSRIs, SNRIs, or trazodone. The reason why I put them there, though, is because many times people don't realize that the SSRIs and SNRIs are not just antidepressants. I think it's a misnomer. I think we should call them antidepressant, anti-anxiety medications, because for the most part, SSRIs and SNRIs are actually good at treating many anxiety disorders in addition to depression. And this is particularly true when it comes to disorders like generalized anxiety disorder, panic disorder, post-traumatic stress disorder, and the like. Benzodiazepines. So the benzodiazepines, those are your Xanaxes, Klonopins, Libriums, Valiums, Ativans, Halcyons, which is not really used anymore, Restoril. So these medications, have a lot of bad press, and there's many reasons for that. But it's important that you know that overall, the way we differentiate the benzodiazepines really is in terms of their onset of action and their duration of action. And that's not always correlated with the half-life. So it's important that you know that in pharmacology, we talk about half-life, we talk about how long the medication is staying in your body, but more importantly is how quickly is this medicine going to work, and how long is it actually going to show an effect. The duration of action or the duration of clinical effect can be very different from the actual half-life of the medication. So for example, Valium. It's a wonderful medicine. It's really good. It's very fast acting, binds very quickly to the GABA receptor, and its duration of action, you can see, is really not that long compared to its half-life. Its half-life is very long, but its actual clinical effect is not that long, 4 to 6 hours. And so what I want you to get out of this table is you have to memorize all of this stuff, but you should know that alprazolam is one of the most rapid-acting benzodiazepines. And sorry, I just had a that was weird. Anyway, so the alprazolam is one that has the shortest duration of action, quickest onset, and because of that, it's also highly abused. So any medication that's going to give you, that's going to basically enter your system quickly and give you a rush quickly is going to be one that's likely to be, it's likely going to have abuse potential. Librium, or chlordiazepoxide, is a very long-acting medication. This is why we use it. We use it for mainly alcohol withdrawal, because you can basically load somebody up on Librium and it'll just kind of taper itself. Okay, so for benzodiazepines, the duration of action and the onset of action of a benzodiazepine is determined by two related things. One, the rate of distribution, and two, the lipid solubility. This makes sense. The more lipid soluble the drug, the quicker it's going to cross the plasma membrane, the quicker it's going to cross the blood-brain barrier, the quicker it's going to get to the benzodiazepine receptor and therefore act, right? The first benzodiazepines were chlordiazepoxide and diazepam. Alprazolam, which is Xanax, was the first benzo approved for panic disorder. All benzos have structural similarity in that they have the 1,4-benzodiazepine ring system, which is shown there on the left. So diazepam has a rapid onset of action due to its rapid absorption and distribution. Diazepam, which is Valium, is very lipid soluble. Interestingly, like I had mentioned before, although diazepam or Valium has a very long half-life, it has a very short duration of action, and actually it has a shorter duration of action than lorazepam after one dose. Intramuscular administration of diazepam and chlordiazepoxide have unreliable and unpredictable absorption. In other words, we usually don't give intramuscular diazepam or Librium, which is chlordiazepoxide, because it's a pharmacokinetic mess, is what I call it. Okay, so this is just an illustration of benzodiazepines and the GABA receptor. You can see that the GABA receptor is made up of 5 subunits. They have alpha, beta, and gamma subunits. This is the, let me just get my pen here, which is new, and just want to show this off. Okay, oh wow, okay, whoa, okay. Did not mean to do that. But anyway, so these are the lipid, this is the lipid membrane, and this is the 5 different subunits. This is the GABA molecule, and then this is the benzodiazepine pill. You can see there's an overall negative charge inside and a positive charge on the outside. And so benzodiazepines, how they work, and I'll show you with this diagram or this illustration. So benzodiazepines, they increase the binding affinity of GABA for its receptor. So when a benzodiazepine binds to the GABA receptor, it actually allows GABA to more easily bind to the receptor, but it also, once it's bound with GABA, it increases the frequency of opening of the chloride channel, which is embedded within the GABA-A receptor. So what this does, it leads to increased chloride influx, and when we know that when you have more chloride inside of the neuron, essentially it becomes hyperpolarized, and when it becomes hyperpolarized, then it's not able to, or it's further away from reaching the threshold to fire an action potential, and so therefore overall it sort of dampens down neuronal activity. This is the GABA receptor binding. I'm sorry, this is the GABA molecule binding to the gamma subunit of the GABA receptor. It opens up. Chloride comes in. There's a bunch of negative charge inside now. And bam, it's hyperpolarized. So benzodiazepines increase the frequency of GABA receptors opening, which means that more chloride can come in, and it's more, it can be hyperpolarized. This is in contrast to barbiturates, which basically bind and then just open up the GABA receptor wide open. And this is the reason why barbiturates are one of the only known substances that can cause complete silencing in the brain, and why it's very important that when you are assessing somebody in the hospital, and this is more for neurology than anybody else, but when you're assessing somebody, the number for brain death, one of the things neurologists have on the criteria for brain death is ruling out barbiturate toxicity or barbiturate overdose. Because when you do an EEG on somebody who has overdosed on a barbiturate, you're gonna see very little, if any, activity. But if you can reverse the barbiturate toxicity, potentially the patient can wake up. So I'm just going to show the illustration again, but this time you're going to see that the benzodiazepine is also going to bind, because I want to illustrate a point. It's important that you know that the benzodiazepine must be bound with GABA in order for the GABA receptor to open. This means that if you have no GABA and you just have the benzodiazepine binding, it's not going to do anything. And this is likely why when you look at dose-response curves for benzodiazepines, that there's a plateau. In other words, you get to a point where you can have more benzodiazepine, but it's not going to cause more inhibition in neuronal activity. Now, if you do a high enough dose, potentially, right? But it's very, very, very hard to overdose and cause respiratory depression from a benzodiazepine alone. I mean, you have to get to very high doses of benzodiazepines to go into respiratory failure. The only exception would be if you're somebody who already has pre-existing cardiopulmonary disease. Another exception would be, and the most common reason why benzodiazepines are implicated in many deaths, is because oftentimes there's alcohol also involved, or opiates, or opioids. And when you combine benzodiazepines and opioids, your mortality risk increases by 4 to 5-fold. And that has to do with the synergistic relationship between the two in terms of respiratory drive. So benzodiazepines are all positive allosteric modulators of the GABA-A receptor. Benzodiazepines that preferentially bind to the alpha-1 subunit of GABA-A receptor are thought to have a more sedative hypnotic effect, while those that preferentially bind to the alpha-2 and alpha-3 subunits of the GABA-A receptor are thought to have anti-anxiety effects. Now, this is something that's more theoretical. There's very little evidence to support this, but this is sort of a theory that you'll hear sort of being thrown around. I mean, there is a little bit of evidence to suggest this, but it's more indirect conclusions than anything. So when benzodiazepines are given to an individual suffering from acute stress disorder, the probability of conversion to PTSD is roughly doubled. What this tells us is that when somebody has just experienced a severe trauma in the acute stage of trauma, benzodiazepines are not good for acute trauma. In other words, if you're going to use benzodiazepines, you're really running the risk of increasing the probability that somebody who has a significant acute trauma is going to ultimately develop symptoms of post-traumatic stress disorder. Exposure therapies for anxiety disorders and PTSD do not work as well if performed in the presence of benzodiazepines. In other words, if you're doing exposure response prevention therapy with someone and you're having them go through some very anxiety-provoking experiences, I mean, part of the whole idea of therapy is to re-experience that anxiety in a setting that's safe. And when you're using a benzodiazepine or using alcohol, you're not really learning, in other words, or relearning this experience. And so obviously this is all theoretical, but we do know that when benzodiazepines are on board, the recovery time or the efficacy, if you will, of exposure therapies goes down. So a short course of benzodiazepines are commonly prescribed when starting an SSRI in patients with high anxiety to minimize the activating side effects that occur when initiating these agents. Almost always, I prescribe a very short course, temporary course of benzodiazepine as you're starting an SSRI. And this is particularly true for individuals who have very high anxiety. The reason why I do that is not because I want to get my patients addicted and I'm just a crazy psychiatrist. The reason why is because when you start an SNRI, initially, especially in people who have very, very high anxiety, you'll see a bump many times in their anxiety levels. You'll see a lot of nausea, upset stomach. For this reason, we start SSRIs and SNRIs in patients with anxiety disorders at a much lower dose than what you would start for somebody for depression. However, you can still get those side effects, and benzodiazepines are really great for that initial bump in anxiety. It can help patients get through that period so that way they can experience the therapeutic benefits of SSRIs and SNRIs. So the following benzodiazepines have little, if any, phase 1 metabolism in the liver and primarily undergo glucuronidation. So therefore, these three medications, oxazepam, temazepam, lorazepam, are preferred for individuals with hepatic impairment. This is because these medications do not go through the CYP450 enzyme system. We know that our bodies have a much greater capacity for conjugating medications and glucuronidation than for the CYP450 enzyme system. When patients are in hepatic failure or they're have a liver impairment, their ability to conjugate medications typically remains intact. The first thing to sort of go in patients who have hepatic impairment is phase 1 reactions. And so for that reason, oxazepam, temazepam, lorazepam are preferred agents. Benzodiazepines have been associated with tolerance, physical dependence, and withdrawal, abuse potential, ataxia, diminished attention, failure of memory consolidation, increased risk of falls in the elderly, and then an increased risk of delirium in the elderly. It's important that you know that long-term benzodiazepine use has been associated with increased dementia risk. Whether or not that's actually true, whether it's confounded by the fact that individuals who ultimately develop dementia are more prone to anxiety disorders earlier in life and therefore are exposed to benzodiazepines much more is still something that needs to be teased out. However, there is that association. So benzodiazepines are mainly used for aborting panic attacks and seizures. They're good for alcohol and benzodiazepine withdrawal. Used in acute agitation and akathisia, used in the augmentation of mania. I think benzodiazepines are very, very good augmentation agents in the acute manic or psychotic patient. It can often quiet down the brain in general, and it can actually decrease their manic symptoms overall. The last thing I'll say about the bipolar mania augmentation or adjunctive treatment is that we often use them not just because for people who are manic are very hyper, but we also want to restore the sleep-wake cycle, and so many times the benzodiazepines are great for helping maintain that cycle. So a brief summary, benzodiazepines are positive allosteric modulators of the GABA-A receptor. They decrease anxiety by increasing the binding affinity of GABA for its receptor and increase the frequency of opening of the chloride channel embedded within the GABA-A receptor. This leads to increased chloride influx and therefore hyperpolarization of the dendritic portion of neurons bearing GABA-A receptors. Risks of the benzodiazepines include tolerance withdrawal, abuse potential, ataxia, diminished attention, and failure of memory consolidation in the hippocampus. Buspirone, Buspar. So Buspirone, or Buspar, is a partial agonist at postsynaptic 5-HT1A receptors. This increases serotonin input to the temporal lobe structures and reduces anxiety symptoms over 4 to 6 weeks. Buspirone does not induce tolerance or dependence, but also does not act quickly to reduce anxiety. In other words, it can be a helpful agent in anxiety disorders, but it's not rapid acting. It takes a while. Its dosing is multiple times a day. So overall, Buspar can be helpful for some patients. However, I don't really prescribe it that much because I don't think it really helps that much or works that well. But it is a medication option, has minimal side effects. It can be used also to mitigate the sexual side effects of individuals who are on SSRIs and experiencing the terrible sexual side effects that we give patients when we prescribe those medications. Sedative hypnotics, we're going to be talking about hydroxyzine, melatonin, and the Z drugs. So we'll start with hydroxyzine. Hydroxyzine is an antihistamine. It reduces anxiety by blocking histamine 1A. It reduces anxiety by blocking histamine 1 receptors. This results in general decrease in the cortical activation. Remember that histamine is not just implicated in allergies and inflammation, but histamine is released from neurons in the tuberomammular nucleus of the hypothalamus, where it has many roles, one of which is in arousal and attention. When we block those H1 receptors, we're basically decreasing arousal and attention. Therefore, this is something that we use in individuals who have heightened anxiety, and it's a favorite among the nursing staff. It's also a good medication that can help with sleep, although I think there are better ones, but hydroxyzine can sometimes be used for sleep. Melatonin and its analogs, I'm not exactly sure why I put this in there, but I'm just going to talk about it for 30 seconds. Melatonin is secreted by the suprachiasmatic nucleus. The suprachiasmatic nucleus is very important in our that's very important in our circadian rhythms. In other words, sunlight, essentially, this is a very simplified explanation, but sunlight inhibits the release of melatonin. Melatonin is thought to give you sort of that sense that it's time to go to sleep. It's nighttime, it's bedtime. When we give melatonin analogs or melatonin itself at night, we're basically trying to recreate the circadian rhythm, and we're trying to replicate the fluctuation in melatonin levels that occur throughout the day. Z drugs. So this is your zolpidem, your Zaloplan and your Zopiclone. These are the Ambiens, the Lunestas, the Sonatas. Again, I'm just going to sort of briefly talk about the Z drugs. So they're not chemically benzodiazepines. We consider them non-benzodiazepines, but they act at the benzodiazepine receptor site on GABA receptors located on neurons of the reticular activating system. Remember that the reticular activating system is, occurs within the brainstem, and it's basically a cluster of a bunch of different neurons or nuclei, and it's involved in arousal and attention. And we know that when we use the Z drugs, as opposed to, for example, benzodiazepines, there's less disruption in sleep architecture, although there is still some disruption, not as much of the benzodiazepines, and in that there's less reduction in slow wave sleep. Slow wave sleep is very important, and when you reduce slow wave sleep, you're reducing that part of sleep that is critical for memory consolidation. And so slow wave deep sleep is very important in sort of rejuvenating our brains so that we're getting ready for the next day. We're consolidating all the memories and stuff and all the crap that you have to learn in medical school and for the exam. And if you don't get enough slow wave sleep, you're probably not going to remember it as well. So the Z drugs, in contrast, or the Z drugs show less reduction in slow wave sleep than the benzos. However, if you've ever talked to somebody who's taken Ambien, or maybe you've experienced this yourself, there is sometimes a risk of dissociative delirium. People will report taking their Ambien at night, for example, and then they'll wake up behind the wheel and have no idea how they got there. This actually happened to a family member of mine, which is very scary. This is especially true with alcohol, if you take the two together. Many times also, you'll find people sleepwalking, sleep eating. These are all side effects of the medication. It's not uncommon to hear somebody talk about how they think that somebody broke into their house and ate all their food, only to find out that it was actually them. Less tolerance and dependence, although there is the propensity for tolerance and dependence, and so we try to use these medications in the short term, although it's often used for chronic insomnia. We should still be careful because there is tolerance and dependence. And then zolpidem challenge we can use for catatonia. Remember, the catatonia, the treatment of choice is IV lorazepam as the lorazepam challenge, but there's also a zolpidem challenge, which is used when Ativan is contraindicated or it doesn't work. Lastly, gabapentin Neurontin. So gabapentin was originally developed as a GABA analog. It does not bind to GABA receptors. It's used as an adjunctive agent in seizure disorders. Its mechanism of action is unclear. It's been shown to increase GABA concentrations in the brain via complex interactions at transporters of the blood-brain barrier. It inhibits catabolism of GABA. It inhibits the synthesis of glutamate. It interacts with an alpha-2 subunit of the voltage-dependent calcium channels. And it's not metabolized through the liver, and it's excreted in the urine unchanged. So this is a good medication for individuals, for example, who have hepatic impairment, and they need a medication that's going to help maybe with their anxiety, or they're going through alcohol withdrawal. This can be a helpful agent. Its uses: epilepsy. It's used for neuropathic pain and post-herpetic neuralgia, fibromyalgia and chronic pain, anxiety disorders. It's off-label for anxiety disorders. It's off-label for bipolar disorder, but there is some use for it in both of those disorders. Whether or not it's really effective or not, there are not enough studies to really determine that. It's used in alcohol use disorders, particularly with the anxiety associated with alcohol withdrawal. It's used in migraine headaches and movement disorders, for example, restless leg syndrome. Side effects include ataxia, drowsiness, dizziness, dry mouth, and asthenia, which is muscle weakness. Thank you for listening. These are the references if you guys want to read a little bit more about these medications. And thanks again.